overall process we know is basically controlled from the hypothalamus. And from the hypothalamus, we have the thyrotropin releasing factor or TRH, which is secreted, which then acts on its receptor to cause release of TSH, which acts on its receptor to cause release of T4. Now, T4 is a prohormone. Now, many of these hormones, if we talk about testosterone, is also a prohormone. Why do I say testosterone is a prohormone?
Because much more level of testosterone is required for similar action as testosterone.
And it is not only a prohormone for DHT, it is also a prohormone for, so it is both ways. Similarly, T4 has got hardly any action on the thyroid receptor. It has to be activated using the monodeiodination. So you've got 4 iodine basically, which is there. You have to remove 1 iodine. If you remove from the outer side, you will get the active form, which is T3. If you remove iodine from the inside ring, you will get the inactive form, which is the RT3. And this is a very important way. Now, how would you regulate your thyroid levels? First, you will say, I will increase or decrease my TRH. I will increase or decrease my TSH, but that will take time, how much you have synthesized. This is the immediate factor. So what you will do is that you will, if you are in deficiency, you will increase the activation, that is MDI1 or 2. If you are in excess, you will activate the MDI3 and say, okay, let's go. So this is the immediate mechanism for providing metabolism. Now from here, they are also bound to globulin or binding proteins. We'll discuss all this in much more detail, but what is the role of binding globulin? One is, of course, that it is carrying the thyroid. Do you think there's any other role?
So it carries and it increases the half-life of.
So it increases the half-life and it will smoothen the level of thyroid. Suppose your hormone is secreted, and if immediately it is changes in the blood, your levels will vary a lot. This is like you are sending in a depot, and from that depot, it is slowly released. So it gives more of a stability. So that's why the binding globulin is important. If you have a problem in which the binding of thyroid to binding globulin is defective, like some of the drugs can do that, what will happen?
So there will be change in the FT4 and FT3 thyroxine levels.
So suddenly your FT4 will go up. So this is like heparin. That is a classic example. Especially if you flush the situation and you give heparin, you will have a sudden breakage of bond between the binding globulin and thyroid, and your FT4 level will go up. By this time, your total hormone is not high and TSH may also not be low. So this is an acute response which happens with heparin that you will see, and that binding globulin becomes important. Now, 99.97% of T4 and 99.7% of T3 is bound to the thyroxine binding globulin. So a small amount of it is only active, and this is what we're going to work on. Now, we'll discuss subsequently that these hormones cannot really cross the cell membrane. So they need special transporters to be transported inside, and then they will go to the thyroid receptor and start acting. So, Dr. Ishita, what would be the steps that somebody who has got a hypothyroidism, thyroid deficiency because of a thyroid problem, what all mechanisms they will do to prevent the adverse effects of hypothyroidism? So, what will be the adaptive mechanism starting right from the TRH?
TRH will of course increase.
Then, second, TSH.
TSH will also increase.
Then
at the like
MDI.
once
1 will go up. Then
T3 will increase.
Then what else? The binding to TBG will go down. So you will have more free amount. MCT8 will be overexpressed. Thyroid receptor will be overexpressed. So this is like an entire defense mechanism. High TRH, high TSH, more MDI1 or 2 activity, more MCT8 activity, less binding, and more receptor. So these are all mechanisms which are there. So if you have a classic example of a fetus who is having a severe hypothyroidism, how much thyroid do you think will be enough to prevent brain damage of normal?
How much thyroid?
In the blood is required to prevent. So because I am said that it is not just the increased production of thyroxine, there are many other things which also play beyond that. So you've got the MCT8, you've got the TBG, you've got the MDI, and all that will prevent the brain damage. So let's say if you say 100 is a normal thyroid, how much they will be able to compensate? So around 30-40% is good enough, because there will be other compensatory mechanism and body will all send it to the brain. It is not bothered about some other region. So that is important. Now, from a laboratory perspective, what does it mean? Which will be the first thing to go up in primary hypothyroidism? Second, to what change we will see?
So after TSH, this T4 to down hoga.
T4 will go down later, and T3?
T3 will be the last to go down.
So T3 is the most unreliable marker of primary hypothyroidism. Now, on the same lines, what are the compensatory responses for thyrotoxicosis? Dr. Naveen, right from the beginning.
It will try to decrease, so there will be a decrease in TRS and there will be a decrease in TSH, and also there will be an increase in the MDH receptor, and there will be down regulation of the thyroid receptors and MDA1 activity, and also there will be an increase in bonding.
So basically, if you've got thyrotoxicosis, of course, TSH is 0, we know that is the first sign you will get. Then you will have a situation wherein your MDI3 activity will go up. So the reverse T3 goes up and the total T3 goes down. The TBG levels go up. Now this is important. Thyrotoxicosis will increase TBG. It also increases SHBG. And that is different, which we'll discuss subsequently. That will cause lesser amount of free thyroid hormone. MCT8 will go down and thyroid receptor will go down. But so according to you, the first thing to go down will be TSH. Second thing to go up will be
FT4.
FT4 according to you, because you said MDI3 is activated, and the last thing should be T3. But then why do we get T3 toxicosis? Which is a situation in which your T4 is normal, but TSH is low and T3 is high.
So in case of iron deficient people, there will be overactivity of this MDA1, which will basically cause the conversion of T4 to T3.
So this is very, very important to understand that normally, if you talk about normal physiology, you will say that thyrotoxicosis, TSH will go down, then your T4 will go up, and then T3 will go up. But if you have iodine deficiency, the adaptory response of iodine deficiency is to increase MDI1. So in that case, you will have a rare situation where T3 is high, T4 is normal, and TSH is low. This is known as T3 toxicosis. So if you understand this slide, most interpretations become very, very easy from that perspective. So let's go more into detail. Now, TRH is the smallest hormone that you will look into in terms of practice. So what is the molecular, so how many amino acids does TRH have? Naveen? Huh? 3. So this is the smallest peptide you will see. Now this is very interesting. If you talk about hypothalamus, then you talk about pituitary, and you talk about end organs. Which hormones are the smallest, Naveen?
TRH is smallest, and apart from that,
so hypothalamic hormones are the smallest. Pituitary ones are bigger than that, and often the end organ ones are much, much bigger. Why? So hypothalamic hormones are more like neurotransmitters. They belong pretty much closer to neurotransmitters than any hormone. They're not really endocrine in the sense. They just have to be there in the hypothalamus and they will work. And their concentration will be the lowest. Hypothalamus will be the lowest, pituitary will be bigger, and end organ will be the biggest concentration because they have to go in the blood. So hypothalamic hormones are very, very small. TRH is 3, GnRH is decapeptyl, 10, decapeptyl, its name is decapeptyl. Then AVP, 9, nonapeptide. So all of these are small hormones in that perspective. So TRH is the smallest. And it being the smallest, it can easily cross through the placenta. So it is one of those hormones which can easily cross through the placenta, even though it is a peptide. So TRH is the smallest one. It is produced by the paraventricular nuclei, the same places where you have got the production of ACTH, you got the production of AVP and other things. And from the paraventricular nuclei, these cells, these will be really going slowly in the form of a pro-TRH, which is converted via pro-convertase. And this is a common mechanism. We talk about pre-pro AVP, we talk about pre-pro insulin, we talk about pre-pro opiomelanocortin. They all have pro-convertase. So they are big compounds and they are cleaved into, and this becomes a tripeptide, a 3-peptide amino acid peptide. From here, it will go with the neuron to the median eminence, and from there to the hypothalamic portal system, it will go to the anterior pituitary and start acting at that. Now, what does TRH do? Which all hormones are affected by TRH?
TRH stimulates prolactin.
First, it stimulates TSH. Its main role is thyroid stimulating hormone, but it also stimulates prolactin. And this is important. So if you have anybody who has got a primary hypothyroidism, you will have secondary hyperprolactinemia because your TRH will stimulate the prolactin in that setting. Now, very importantly, these peptide hormones will be destroyed within minutes. So there is no role of measuring TRH in the blood. Now, many of you will say, okay, TRH is being crossing the placenta. It crosses the placenta and mother has a primary hypothyroidism. But that child then, why doesn't he become thyrotoxic? Because TRH is high in mother, very high. You don't know TSH is more than 100. TRH is high. Then
but these don't cross.
These cross the placenta. But this does not go to the blood. So the TSH level in the blood will be very high, but TRH level will not be very high. So even though it crosses, it is just destroyed as soon as it reaches the blood. So it will not be high in the mother's blood. It won't go to the placenta and cross the placenta from that perspective. So it is very short half-life. Now, thyrotropin releasing hormone is a typical situation of a G protein coupled receptor. So it basically acts mainly through the GQ11 pathway using the protein kinase C. And what it would do is that it will produce both alpha subunit and beta subunit. So it will produce both alpha and TSH beta subunit, and they will then produce TSH. Now, what is important about the alpha subunit? Dr. Manoj.
In some tumors, alpha subunit will be increased, so we can measure and we can diagnose.
So that is when you have a discrepant production spontaneously from the thyroid. That is different. But why I have written TSH beta? I have not written TSH alpha. Why?
Because alpha subunit is similar to other hormones.
So it is the same, not similar. Alpha subunit is the same for the which hormones?
LH, FSH, HCG.
So, and what are the chemical structure of these hormones? What are they in common? They are
Peptides.
and peptide is there, but what else? They are peptide with they are glycoproteins. So all of them are glycosylated, and this is very important because glycosylation, when I talked about LH, FSH and HCG, I said the more you are glycosylated, the longer you will have actions there. So TSH is also a glycoprotein. So this belongs to a glycoprotein group of hormone, and this is therefore sent to the area for modifications where post-translational modifications will happen. And this is also a very good way. Suppose you want a greater action of TSH, you will glycosylate less. If you want more action of TSH, you will glycosylate more. Similarly, when we talked about PTH, you remember that if there is hypocalcemia, the active form of PTH will be released more. The passive, the carboxy terminals will be reduced. But when you don't want, your carboxy terminals will go up. Similarly, the TSH with glycosylation will come down if you have a primary hypothyroidism. What does it mean in terms of assays? When you measure an assay, what do you think how would that impact? So what I'm trying to say very importantly is that in altered thyroid function states, the bioactivity of TSH may differ because the amount of glycosylation is different. So how will the assays be affected? So it basically means that the immunoassays and bioassays may have a variation. But generally speaking, it is not that huge. So generally we all measure immunoassays. But what you need to understand is that if you say immunoassay is 100, doesn't mean that this is the biological activity. Maybe this TSH is more active in that perspective, and you may have less active TSH also if it's more glycosylated. More glycosylation means more heavy, doesn't go that much in terms of activity. Now this is what I was talking about. Alpha subunit is common between all these compounds. So if you talk about LH, FSH, HCG and TSH, alpha is the same. Beta is also similar. The length of beta and the glycosylation of beta will determine the biological activity and the half-life of that particular product. Now, what are the implications, Dr. Vibha, of the similarity of HCG and TSH?
Similarity of HCG and TSH. So, like in pregnancy, when the HCG is more, so sir, it will
Act on the
this
TSH receptor and cause
stimulate it.
so causing relative thyrotoxicosis. Now, when I say structural similarity, I'm not saying that if you have 2 units of TSH and you have 2 units of HCG, they will have a similar effect. No, it's a hundreds and thousands. But in pregnancy, you will get thousands of HCG. So that thousands of HCG will stimulate the TSH receptor and it will cause reduction in TSH by 1 point. So during pregnancy, on an average, the TSH goes down by 1 point. That is why the cutoff for pregnancy is 4 when we talk about diagnosing of hypothyroidism. So this will have relevance. What about the similarity between TSH and FSH? What clinical situations are they relevant, Naveen?
In case of severe hypothyroidism, which cases cannot act on the FSH and result in the formation of ovarian cyst, which may result in withdrawal bleeding and also breast development.
So ovarian cyst and
breast development.
And in boys?
So in boys, there will be
macroorchidism. So it will have a apparent FSH excess sort of a state you will get in that perspective. So if your TSH is high, as Naveen has said, it will act on the FSH receptor, which will cause large ovarian cysts in girls with peripheral precocious puberty with short stature and delayed bone age, which we have discussed many times. And it will also going to act on the testes. So you will have got macroorchidism without penile enlargement with no pubic hair. Now, why is there no pubic hair in both these cases?
Because TSH will stimulate the prolactin. So prolactin having mainly FSH predominant action. So if LH is low and FSH is high. So because of the LH suppression of LH, there will be no pubic hair.
Very importantly. So one is, of course, some people talk about bone age, but the major effect is hyperprolactinemia. So long-standing untreated. I'm not talking about TSH of 15, 20. You're talking about more than 100 for quite some time. Then it will cause apparent FSH excess and LH deficiency because prolactin has gone up. And that's why there is no pubic hair. So breast development, vaginal bleeding without pubic hair. Hypothyroidism is an important thing with short stature and delayed bone age, which is there in that perspective. Now, placenta, we all know, produces HCG, and this is what we discussed. It will act on the TSH receptor, causing a relative thyrotoxic state, and that will be important from that perspective, and you will have that problem. So this structural homology will have a significant impact when we look for assessment of different conditions. Now, TSH also acts on the G protein coupled receptor. The major impact is via the cyclic AMP GNAS1 pathway. And once it goes there, its major impact is on production and release of thyroid. We'll talk about it. It acts at the iodine importer, it acts at the TPO, it acts at the organification, it acts at the release everywhere. So it will increase the thyroid and you will have release of thyroxine in that regards. It also has an impact via the PI3 kinase pathway to cause increase in the size of thyroid. So if you have somebody who has got a complete, let's say, central hypothyroidism right from birth, maybe there is anencephaly, what will happen to the thyroid size? Will thyroid be formed or not? First of all. So there is no TSH. Will you have a thyroid formation or not?
As you said, that TSH is important for the thyroid growth. But the thyroid will be present, sir.
So that's what I am asking. You have to tell me. So thyroid will be there or not first?
It will be there.
Will it be small or big? Naveen?
So it will be small.
It will be hypoplastic. So it is there, it is being formed, but you are not giving it water. Your tree is planted, you're not giving it water because TSH is the major stimulant. So you will have hypoplastic thyroid, which is there, and that thyroid may actually be missed on a scan. Now, scan will show what in this situation? Scan will show?
Sir, mostly no uptake.
Why?
So because
you don't have any TSH. Your TSH is not there, so sodium iodine importer is not there. So how will there be uptake? So there will be no thyroid on a scan, but when you do an ultrasound, you will see small thyroid. So this is known as apparent athyrosis, and conditions that cause this include TSH receptor problem, sodium iodine importer defect, or a maternal TSH receptor blocking antibody. So all of these conditions will cause this situation. So TSH is important for cellular growth as well, and that is through the pre-I3 kinase. Now, when I talk about G protein coupled receptor, what does it mean? Which disorders can cause hypothyroidism and other hormonal deficiencies?
Hypothyroidism, but GNSA inactivating,
Which is
like EHP.
pseudo-hypoparathyroidism, and you will have high TSH and high PTH. The level of TSH elevation in these cases may actually be good enough to be picked up even on screening. So if you have an obese child who comes to you around 6 months or 1 year of age, TSH is 8 to 10, think of pseudo-hypoparathyroidism. In that case, you may have subclinical hypothyroidism, subclinical pseudo-hypoparathyroidism, and then that is the AHO phenotype which is causing obesity. Which conditions will cause thyroid excess?
So activating mutation.
Yeah, so GNAS activity. So McCune-Albright can cause thyrotoxicosis, as we discussed in that setting, and that comes from here. Now, very importantly, how is this feedback mediated? So when we talk about thyroxine, we know the feedback is there. The feedback will mainly happen through T3, not T4, because T3 is the active hormone. So the T4 is activated into T3 in the brain, and this T3 will then suppress TSH, TRH first, which is the first feedback loop, and then there is a shorter feedback directly at the TSH receptor, also the MCT4. And there is also a local impact of TSH. So there are multiple mechanisms which will negatively suppress. So immediately it will suppress TSH. If it is high, it will suppress its own secretion, paracrine effect. T3 will suppress both TRH as well as TSH. And this is what we've discussed. If you have hypothyroidism, TRH will go up, that will cause hyperprolactinemia. TSH will go up, and that will cause precocious puberty, and you will have microorchidism, which will develop from that perspective. Now, how is TSH regulated? So whenever we talk about the tone of the regulation from the hypothalamus to the pituitary, generally the tone is, Dr. Naveen, is it inhibitory or stimulatory? So general tone is inhibitory. Really? So pituitary is stimulated by the hypothalamus or inhibited by the hypothalamus?
So it is stimulated by the So pituitary is stimulated by the hypothalamus.
So it is stimulatory tone, whether it is growth hormone releasing hormone, whether you have corticotropin releasing hormone, you have GnRH, except for prolactin. So you have a positive tone which is coming mainly at the level of TRH, which is causing stimulating. What else increases TSH secretion?
There could be cortisol deficiency.
No, I'm not talking about deficiency. That will be the other way around. So what other stimuli will cause TSH to go up? One is TRH. What else?
Low levels of FT4 and T4.
That is secondary, but anything else? Cold. So if you have a cold stress, your TSH will be stimulated. Now, what things will inhibit that? Dopamine and cortisol and somatostatin. These three will inhibit TSH level, and these have significant implications. So if you have somebody who has got a primary hypothyroidism, let's say congenital primary hypothyroidism, you find that his T4 levels were, TSH levels were not high, and you discharged. He was in the ICU for some time, received some treatment. But later on, he tend to found that the TSH has gone up. What are you thinking? A sick neonate had a normal TSH earlier on screening, but repeat screening showed a high TSH. You will look at history of dopamine, or you can think of somatostatin if it is given some reason, or steroids. A lot of all this will cause suppression of TSH. So that becomes important from that regards. T4, dopamine, somatostatin, and severe illness, they will all suppress the TSH level in that regards.